Hi, my name is Lara Motta and I'm the International ACE Programs Coordinator, and today I'll be presenting some of the preliminary findings from our pilot project of the ACE program in Northwestern Ontario. This presentation will form the basis of the report for the Governance Committee of the annual pilot project. But firstly, before I get started, I'd like to thank each and every one of you as point of care operators, because without your tireless work, the ACE program would not be a success. So what is a point of care test? A point of care test is a pathology test that is performed on a small device in a clinical setting outside the laboratory at the time of the patient consultation, with the results immediately available for patient care and management. A point of care test can be a biochemistry test, hematology, microbiology, or pharmacology test. Point of care tests can be both quantitative, that is, they generate a number or value, or qualitative, that is, they detect just the presence or absence of a disease. In Australia, our centre has developed point of care testing models for chronic, acute and infectious diseases that have proven safe, clinically and culturally effective, and analytically sound in geographically and clinically diverse settings, most notably rural and remote Indigenous communities. The QAMS program is the largest national point-of-care testing network in Australia, providing point-of-care testing for diabetes management in 175 Aboriginal and Torres Strait Islander medical services, of which more than 70% are rural and remote. In QAMS, hemoglobin A1C, a marker for long-term diabetes control, and urine ACR, a marker for early renal disease, a major complication of diabetes, are measured on the Siemens DCA Vantage. These tests are done on a finger prick of blood and a drop of urine, with results available in under 10 minutes. In 2012, following many requests from overseas countries for help with point-of-care testing, we decided to translate successful elements of the Australian QAMS program to an international audience through the ACE program. Like QAMS, ACE has a strong emphasis on community engagement and empowerment. Through collaborative research partnerships with international universities and professional organisations, ACE has been introduced to 35 community health services with high diabetes burdens in Canada, South Africa, Thailand, East Timor, Papua New Guinea, Solomon Islands, and Samoa. For the pilot project of the ACE program in Northwestern Ontario, we formed a partnership with St. Joseph's Care Group in Ontario and the Northwest Local Health Integration Network. This presentation specifically discusses the implementation of the ACE program in Ontario and summarises findings relating to education and training methods, analytical quality, and results of patient testing to date. Ethics clearance for the project has been granted by the Government of South Australia's Southern Adelaide Clinical Human Research Ethics Committee, as well as the St. Joseph's Care Group Research Ethics Board in Canada. There are 22 participating communities from the Northwestern Ontario region, with 15 currently actively participating, that is, they're sending monthly patient and quality control results, and 7 currently inactive due to having either no staff trained at the centre, waiting for medical directives, or they've decided to withdraw. For privacy reasons, in this presentation I will refer to each of the communities by their ACE program community number. Given the diverse range of locations we deliver our programs to, it is important to offer flexible options for training. In the ACE program, we offer a number of different training options, including, for most of our overseas communities, self-directed e-learning via our website, training via video conference or Skype, or for some communities, we are able to offer face-to-face training at our international centre in Australia. For communities in the Northwestern Ontario region, we have used self-directed e-learning and Skype. Across the Northwestern Ontario region, 43 health professional staff, mainly nurses, nurse practitioners and diabetes educators, have completed ACE program training and competency and now qualified point-of-care testing operators. As you know, Each community performs monthly quality checks using 2 levels of quality control material supplied by Siemens. This quality control material contains artificial blood samples that are made up with water. They contain known values. For example, normal quality control contains a normal level of HbA1c, and abnormal quality control contains a high level of HbA1c. The point-of-care testing operator records their QC result on a colour-coded result sheet, which enables them to immediately check on the quality of their test result, i.e. how well their result compares with the known value, and whether it is safe to continue patient testing. These results are then sent to me at the centre so that I can track each community's performance and ensure that testing is equivalent standard to laboratories and safe for patient testing. Imprecision, or CV, is a key performance indicator of analytical quality used by laboratories across the world to monitor quality of pathology testing. In simple terms, the lower the imprecision, the better the analytical performance of the device. For HbA1c, laboratories and health services in ACE are expected to be able to achieve a minimum goal of 4% or less, and ideally a desirable goal of 3% or less. As you can see from this table, collectively, the Northwestern Ontario communities participating in the ACE program met the desirable imprecision goal for both levels of HbA1c quality control, with imprecision of 2.4 and 2.8 respectively. In terms of individual sites, on this graph you'll be able to see how your individual service has been performing. As you can see, all but one community for one level of quality control are achieving the minimum goal for imprecision. 1011 has had some staffing issues and has only performed 6 quality tests so far. We expect the imprecision will decrease as more quality control tests are done this year. Overall, these quality control results show that the point-of-care operators in the ACE program have demonstrated sound analytical performance across all participating communities. Moving on now to patient testing. Each month your de-identified patient test results are collated by St. Joseph's Care Group and sent to me. This allows me to analyse your patient data, identify any trends, for example, patients whose HbA1c levels have increased or decreased suddenly, or patients who are being tested more or less frequently than recommended, and provide monthly feedback to St. Joseph's Care Group to let them know how the pilot project is going. So what do your patient test results look like so far? Well, as of January 2015, over 1,100 HbA1c tests on 978 individual patients have been performed across the Northwestern Ontario communities. 772, or just under 80% of patients tested, are either patients with non-diabetes or with HbA1c levels greater than 6.5%. The mean HbA1c level in these patients is 8.4%. You can see that 156 patients have returned for repeat testing. As you'll see on the next slide, this repeat testing data is really important to show the clinical effectiveness of the ACE program by demonstrating that point of care is assisting in improving diabetes control in patients in your community. And so it would be great if you could encourage your diabetes patients who are due for a repeat HbA1c test to attend the clinic over the next few months. This would mean that, perhaps next year, we would be able to add a column to the table showing that the mean HbA1c in diabetes patients from your community after 12 more months has ideally fallen. This slide shows patient results from one community using 2 devices that have done over 500 hemoglobin A1c tests under the ACE program framework. Please note that this community has been participating in the ACE program for 2 years. Due to the large number of repeat tests that have been done on patients in this community, meaning that patients have returned for a second or subsequent test, I've been able to monitor glycemic control over time among this group of patients. This table shows that the introduction of point-of-care testing to this community has resulted in improvements in glycemic control, as shown by a 0.5% reduction in hemoglobin A1c in a group of 105 patients over 12 months. So where to from here? The funding provided by the Northwest Local Health Integration Network for the annual pilot project of the ACE program in Northwestern Ontario concludes in April 2015. We hope that the data we have collected so far, and will continue to collect, will provide evidence for the clinical, cultural and analytical effectiveness of hemoglobin A1c testing under the ACE framework. This will help to raise awareness and attract funding for the continuation and hopefully expansion of the ACE program in your region. As I mentioned, it would be great to be able to analyse repeat patient test results for all of the communities. To do this, it would be good to see a minimum of 50 repeat test patients at each community, so I urge you to encourage your diabetes patients who are due for repeat testing to attend the clinic. As another aspect of the program, we would like to evaluate the stakeholder satisfaction. That is, how do you, as point-of-care testing operators, feel about point-of-care testing? What does it mean for your clinic? What are the advantages or disadvantages? And do your patients like having point-of-care testing available to them? To do this, we'll ask you and your patients to complete satisfaction surveys, which will be sent to you over the next few weeks. If you have photos of you using the DCA Advantage or have comments about the program, I would love to hear from you, so please send me an email. Thank you for your time.